Hi, everyone. This is the New York Medical College Student Interest Group in Neurology podcast interview series. My name is Emily Rudmann, and I'm a second-year medical student, and I'm joined today by Dr. Sneha Bagchi, an epileptologist at MidHudson Hospital.
Hi,
Thank
everybody.
So to start, I'd like to ask you, could you tell us a little bit about yourself and your journey to becoming a physician?
All right. So, being a physician has basically been a dream of mine since I was very, very small, and it never quite went away. I think I just had more reasons to actually do it as I got older over time, as opposed to, hey, this sounds very cool. I liked biology. Um, I liked the puzzle of it all, and I liked the idea of helping people in undergraduate school. Um, I did research as well, and I was actually doing neurobiology as my major. And I did do research, and research is a really important part of medicine nowadays. But I realized it really wasn't my path in that case. I really wanted to work hands-on with people, have encounters, see if I could actually improve their lives in that moment, as opposed to knowing that my work would contribute to something later on.
That's great. Thank you so much for sharing. And it's always interesting to hear how research has factored into everybody's journey, because I think most of us have had a stop along the way that included research. So that's really interesting. Thank you. Next, I wanted to ask you why you chose neurology as a specialty.
So I was a neuroscience major when I was an undergrad, and I knew I liked the theoretical part of neurobiology. What I wasn't sure about is whether I would like it as a specialty, as something to actually practice. So I didn't really decide on neurology until I was doing my third year medical school rotations. And I thought I might do OBGYN, I might do pediatrics. And for various reasons, I decided not to. Mostly, I'm not a surgeon. I'm really not a surgeon. And I like kids very much, but I don't think I want to be their doctor. Um, and in neuroscience, people were very open. They wanted the students to be involved, to be enthusiastic, and it's fun. It's like you have such a huge range of patients. You have patients with migraines, which half of us experience, and you have patients with really terrible genetic diseases and a huge gamut in between. And I really liked the range of that too. And the physical exam. I actually really, really liked the physical exam. It felt like the one specialty where it actually really, really mattered.
That's so interesting. And you kind of addressed my next question, which was if you were deciding between other specialties, it sounds like you considered OBGYN and pediatrics.
Yeah.
Could you speak, yeah, a little bit more on how you kind of ruled those two out?
I think I realized that when I was in OBGYN that I liked talking about contraception, I liked talking about family planning. That's kind of a passion of mine. I liked talking to women about their health, the choices that they made, how they experience pregnancy, how they experience menopause. What I realized is I hate the OR. I did think C-sections were very, very cool, but I couldn't stand being in the OR. I liked clinic. And I just, besides a C-section, which is very short and at some point someone's ripped into by bare hands, um, like it didn't appeal to me at all being in the OR.
That makes total sense. So you are a newer attending, recently out of fellowship, and so you have a unique perspective to offer on these next few questions. But I wanted to start regarding your current practice with asking you what conditions do you treat?
So I'm an epileptologist, so that's my main specialty. So I see patients with epilepsy primarily, but I also see people with PNES. I see a lot of patients who are referred to my clinic for person who lost consciousness and we don't know why. And I also still see general neurology as well, so headaches, numbness, tingling, all of that fun stuff.
And so as an epileptologist, I imagine the most common condition that you see and treat is epilepsy. But I'm curious to know what is the balance between outpatient and inpatient practice that you have, or are you purely outpatient?
So that kind of balance really does depend on the institution and what they need you to do at the time. For me, I wanted a mix of both. So I do outpatient clinic most of the time. I'd say like 60, 70%. And I'm hoping to make that more of an epilepsy specialty clinic up in MidHudson. But again, since I'm a new attending, I have to build up that practice. It takes a little time to get a specialty clinic going. But that's the majority of my time. Then I spend 8 to 10 weeks on inpatient EEGs. So I read the continuous EEGs, LTM, also read some of the inpatient routines. And 6 to 8 weeks or 4 to 6 weeks I spend on inpatient epilepsy monitoring unit. So um, if we have patients admitted for epilepsy surgical evaluation or to determine if episodes that they're having are seizures or not seizures, I will be the main attending on that service. I'll also read the outpatient EEGs, the ambulatory EEGs. So that's also a bit more inpatient, although more like a service. And then as well, up at MidHudson on Wednesdays and Thursdays, I do general neurology consults. So it's a
That sounds
pretty
like
good
a
mix.
Yeah, I was just about to say that sounds like a really great balance. And with certainly a lot of interesting different kind of ways of looking at epilepsy, which
Hmm.
yeah, it's really interesting. So next I wanted to ask you, how is your work-life balance? And then I guess you can maybe speak to as a new attending, what it looks like and maybe how you see it progressing in the future.
As a new attending, it's definitely better than fellowship, definitely better than residency. Um, I am very happy that most of my weekends are free. And when I'm on call, people have very good boundaries about here's when you start, here's when you end, here are the calls that you get, here's what we expect of you. And I think those clear expectations are important when it comes to work-life balance because then you can draw a line and say, okay, after this, that's it. It's someone else's job. I will help out if you need me to. But these are the boundaries of my work. And beyond that, I have quite a lot more free time than I did in residency and fellowship, which is, again, very nice. Um, I don't have children right now, and I'm not married yet. So I go into the city a lot. I see my friends. I go to shows. I go to concerts. I um, go to nice dinners. I go on vacation, which I haven't yet, but next year.
Yeah, I was also going to ask you about your vacation habits, but I think what you described is definitely, I think, a lot of people's hope for what comes after the more intense phases of training. So it's great to hear that you're able to, enjoy your life and as an attending. So one of the questions that I did want to ask is vacation. So, do you go on vacation? How often do you go on vacation?
So in residency and fellowship, I had 2 vacations a year, usually 2 week blocks. It's similar as an attending. You have 4 weeks of vacation time, more or less. Um, but you can scatter them out like a corporate job would. So you can take a few days here, a few days there. You can take a week, you can take 2 weeks, you could take your whole month, but that would be a bit much. So there's a lot of flexibility in that sense. But in terms of the actual amount of vacation time, it's about the same as residency.
Okay. Um, I'm curious to know how many hours a day slash week do you typically work, and how is this different compared to residency?
I mean, one of the reasons I wanted more outpatient time is because it's closer to kind of a classic 9 to 5 with weekends off. And right now, I'm still working on filling up my clinic, but right now, my hours are from 8 to 5 on a clinic day.
Mhm.
Um, It's the same for consults inpatient 8 to 5. Um, LTM is from 7 to 5. Uh, and epilepsy monitoring unit is also 7 to 5. And then in terms of overnight call and weekends, I share with other attendings, and we all have the same amount of call, more or less. So I would say I only work one weekend every 4 to 6 weeks.
That's great. Um, my next question for you is, do you have any advice for aspiring neurologists?
Oh God. You are going to see a huge range of patients, and you have to keep an open mind. You're going to see a lot of common things. You're going to see a lot of zebras, and you have to be open to seeing zebras even if you're seeing the same loss of consciousness patient for the 50th time. And similarly, it is really easy to get angry at the other services. It is really, really easy, especially when you have the dumbest consult request you've ever seen in your entire life. But sometimes you have to realize that we have spent so long in residency, in fellowship, that so much about neurology is second nature. We don't think about it, we don't have to think about it. It's super easy to us. And that's just not the case with other services. And it's really easy to forget that sometimes. And you want to be patient. You're like, okay, what do they actually want to know? And really good communication with other teams is a great learning experience for you as well. Because once you're done with your medicine year, the first year of residency, you'll think, oh, I'll remember all of this. I know how to treat DKA off the top of my head. This is what we do for sepsis. And then 3 years later, you're like, how do I treat pneumonia again? So
Yeah,
keeping an open mind is always really helpful.
that's really good advice. I'm also interested, this is kind of off script, but if you could speak a little more on what you took away from your intern year as you progressed into obviously neurology residency and now as an attending.
My intern year was 2020.
Oh, okay. That answers that.
So, I mean, I can tell you what that felt like, but um, I mean, I came into intern year after the initial surge in Queens.
Okay.
Um, so I started in July. The surge had been around March. And so in the summer, you got a pretty normal medicine experience. They have step downs, ICU, regular floor. I was in Queens, and we had a lot of alcohol withdrawal, cirrhosis, a lot of COPD as well. So those very, very classic internal medicine patients. And then right around November, December, January, COVID just surged. And so then all of a sudden, not all of a sudden, but before you knew it, you were doing a dot phrase for every single one of your patients because they're like, patient comes in with shortness of breath, fever of 101, pulse ox was 89 on room air. We're going to give steroids and go from there. The vaccine came out when I was on my ICU rotation.
Wow. So definitely a very historic and unusual intern year. Um, my next question for you is, what do you see as the biggest challenges facing neurologists today?
An interesting one. I mean, when you're an attending, what you realize is there's way more administrative barriers to taking care of your patients, especially outpatient, like insurance coverage, especially. There are a lot of hoops to jump through. But the nice thing is that there is a lot of new research in every single field, not just epilepsy, but MS has so many exciting things going on. So does movement disorders, dementia, and cognitive neurology has so many interesting new tests and everything. And I think the risk is just falling behind more than anything else. Like it's very, very easy to realize that, hey, I have over specialized or I've just been seeing the same patients over and over again. And while I was doing that, there are like 20 new tests. or 20 new like medications. And I think that is really important for every neurologist to know is like it's not the 1990s, it's not even the early 2000s where we didn't have treatments or our treatments were extremely limited. Like things are changing all the time and we need to keep up with that.
That's a really great perspective. I wonder, another off-script question, how you see the role of like attending conferences and sort of keeping up to date. Do you think that's one of the ways that you can kind of stay on top of things?
I really wanted to stay in an academic institution because you guys have conferences, the students rotate through, we need to teach, we need to go to grand rounds because as a resident, I don't think I appreciated that enough. You're busy, you're taking care of your patients. It feels like a pull on your day, but as an attending, you're like, wait, all of this is happening? I don't remember any of this. Or even just, new topics. And when you work with students and the residents, you also get to practice those topics. You get to understand those topics in better detail. So it's good for the attendings as well.
Definitely. And I think obviously the students, receive a huge benefit from having such involved academic attendings who are excited to teach. So I'm personally excited to enter my third year and kind of experience that more. Um, I have two last questions for you. So the second to last is how do you think the field will change over the next few years and even further down into the future?
Oh, the field is going to change so much, so dramatically in the next few years. But I mean, admittedly, I don't know how much of that is going to change based on the current administration and what research is approved. A lot of things might just be frozen for a few years. But ideally, assuming that things progress as they're supposed to, I think there are going to be a lot more new devices, both in epilepsy as well as movement disorders. We are doing so much with DBS, RNS, epilepsy surgery, especially new medication trials, and our colleagues in neuromuscular and neuroimmunology have all these really interesting new medications all the time, and you're getting such amazing outcomes for patients as well that are so different from even 5 years ago. So I think things are changing really fast. Or at least, and the hope is that we still continue that rate of change and that rate of improvement.
Definitely. It's very exciting to see all of these, you know, minus this slowdown, which is temporary. It's exciting to see what will come down the pike. Um, okay, final question for you. What is your favorite part of the brain or the CNS and why?
Ooh, okay. I'm Everyone has to decide whether they're a peripheral neurologist or a central neurologist at some point, at least internally. I'm definitely a central neurologist. Um, Temporal lobe is so interesting, honestly. Um, even just not, Even if we're just excluding the Papez circuit and the way memories are encoded, the way everything is so intertwined in terms of the limbic system, memory, language, um, perception of sound, and it's so intertwined and it's so much fun to say like, hey, one gyrus versus the other gyrus, and how does that translate into the symptoms that our patients are feeling? Can we locate it to just one gyrus or one sulci? It's really fun that way.
Great choice. It makes a lot of sense as an epileptologist, because I think temporal lobe epilepsy is so fascinating and the symptoms so varied. Um, so that was my final question for you. Do you have any final words of wisdom that you'd like to share?
um if you're already interested in neuro, then I think that's already a wonderful start. And the more you practice it and the more you see patients with different neurological diseases, like you're going to have such a huge and wide and varied perspective on what patients are and how we interact with them. Ooh, okay, I've got a cold. Mm. But yeah, we talk about disability a lot with our patients, and a lot of our patients aren't curable. And even with all the amazing treatments and devices that I was talking about, they're not curable. Um, but it's still important to do the work, um, and meet them where they are.
That's great advice.
Sorry.
No problem at all. Thank you so much for joining us, Dr. Bakshi. This has been such a great conversation, and I'm excited to share it with the students and the wider audience of YouTube. Um, so again, I've been speaking with Dr. Sneha Bagchi, and we're so grateful for your joining.
Yeah, no, thank you so much for inviting me. I really do appreciate it.